Welcome to our sixth webinar in our breast health series as we follow the patient pathway from screening mammography to surgery. In our last episode, we spoke with our physician panel about lesion localization prior to surgery. And today we're going to take a deep dive into the common types of breast cancer, the different breast surgery techniques, and the treatment pathways available today. We're so glad you could join us.
Hi, my name is David Weintritt. I am a breast cancer surgeon in historic Alexandria, Virginia. I have a position in the faculty of the Department of Surgery of George Washington University and a directorship of a program in the Inova Health System in Northern Virginia. And I also run a breast center and a breast cancer foundation in my practice in Alexandria.
I'm Candace McGuire. I am the Chief of Breast Surgery at the Virginia Commonwealth University Massey Cancer Center.
So Dr. Weintritt, breast cancer is often described by whether it's found to be in situ or invasive. Can you explain for us the difference between an in situ and an invasive breast cancer?
The difference between in situ and invasive breast cancer, it's a microscopic evaluation. So I always tell patients when a biopsy is done, a pathologist is looking at the tissue under the microscope. The first thing they're going to assess is, do they see cancer cells or not? The second thing that they will assess, if they do see cancer cells, is are they contained within the original structure in which they occurred, which when we're referring to breast cancer will be either the milk ducts or the milk glands, so ductal or lobular. When they are evaluating the cancer cells under the microscope, if they see the cells invading through the wall of either the duct or the gland, then the diagnosis is changed from in situ to invasive. It does not mean that there has been spread further, but that invasion through the wall into the adjacent breast tissue, which equates to an invasive breast cancer diagnosis, then requires us to be considerate of other issues, which is why it's such an important distinction.
What is a typical or common treatment pathway for someone with invasive cancer?
Patients who have invasive breast cancer, the typical treatment pathway begins with the discussion of the staging of their disease, and that is initially done clinically, where we assess what do we believe to be the extent within the breast? Do we believe that there is any involvement in the lymph nodes under the arm? Do they demonstrate any symptoms that we're concerned about for disease or breast cancer that could be spread elsewhere? Once we have a good sense of their stage and we have a sense of the type of their invasive breast cancer, then we shift to actual treatment. The treatment involves three specialists. One would be breast or surgery oncology. The other would be medical oncology, which involves the conversation of both medications that you would take by mouth or those that could be done intravenous, which everyone's familiar with that concept of chemotherapy. And then the third would be the radiation oncologist who would provide radiation.
So once a patient has been diagnosed, how soon should they begin treatment or have any surgery that's recommended after the diagnosis?
Once a diagnosis of breast cancer happens, there absolutely is the thought of get this out. I want it gone. Treatment needs to happen. And please do it yesterday. It's very important to have a thorough understanding rather than rush into surgery. And to make sure that individuals, both surgeons and patients, are very comfortable with the plan that they're recommending and that they're accepting. Occasionally, we'll look at a scenario where we really need to get something underway within a matter of weeks. But for the average early stage breast cancer patient, ample time, evaluate properly, understand options appropriately, get comfortable with the team, and then begin treatment roughly 2 to 4 weeks after diagnosis. And that is an absolutely safe window, which could even be pushed further in most cases.
When a person is diagnosed with breast cancer, one of the areas that must also be evaluated is the axilla or the underarm area. This is because if breast cancer has spread, it typically goes to nearby lymph nodes first. These axillary lymph nodes are commonly evaluated by clinical exam first and possibly ultrasound. and your physician will determine if any further testing needs to be done. If lymph nodes need to be removed during surgery, one procedure that a surgeon might perform is called a sentinel lymph node biopsy, where only a small number of lymph nodes are removed. In other cases, a larger number of lymph nodes must be removed, and this is called an axillary dissection. Axillary surgery can have complications, however, like lymphedema, numbness, and pain. We'll hear more about lymphedema next. Can you explain what lymphedema is and maybe explain who's at a higher risk?
So yes, so lymphedema is swelling of a part of the body due to lymphatic obstruction, and it can happen for a number of different reasons in a number of different parts of the body. But when we're talking about breast cancer surgery and axillary surgery, it's primarily swelling of the arm, although you can have breast lymphedema. And the symptoms are typically a heaviness or a discomfort in the arm. That's the first symptom. And then you can actually tell a measurable difference between the two limbs if you actually measure as things progress. And lymphedema can be mild. It can be intermittent. It can be very severe. It can be permanent. It can be disabling. And you never know who's going to be who ahead of time. So that's why throughout the decades, we've been working on ways to reduce the rates of lymphedema. Rates of lymphedema when breast surgery first started, when we were doing what we called a radical mastectomy and removing 3 levels of lymph nodes, were upwards of 50 to 60%. Now with modern axillary lymph node dissections, we can get that down to 15 to 30, depending on patient factors. And with sentinel node biopsy, we get it down to, like I was saying, 3 to 11%. And so it's widely variable. There are a lot of patient factors that go into lymphedema. Being overweight, having a sedentary lifestyle, those sorts of things really predict highly for lymphedema. So anything we can do to reduce that risk, we've been trying to do. And so once one woman has lymphedema, it doesn't really ever go away. It can be treated with massage techniques, compression techniques, a lot of postural things that women can do. We talk about prevention of lymphedema with not doing blood pressures and IVs on the side of your lymph node surgery, but actually none of that is supported by data. So really our goal is to just have it not happen.
What are other complications of axillary surgery besides lymphedema?
When surgery is done in the axillary or armpit region, lymphedema is sort of the most worried about or oftentimes most discussed complication. But there are other things that can occur with surgery in the axilla. There are nerves, in particular sensory and motor nerves, that are in the area of the operation. There can be a decrease in sensation, generally speaking, in the outer part of the chest or the upper inner part of someone's arm. Then there are motor nerves, which are involved in stability of your shoulder. And so similarly, when lymph nodes are being removed from the arm, you need an experienced surgeon who knows where the location of those nerves are to avoid issues with long-term problems from weakness or instability of your shoulder area. Other issues that can occur, there's a very frequently discussed condition called axillary webbing or cording. So when someone were to reach up or out, they have a sensation of something tethering or pulling on their arm. And that is traditionally referred to as that cording or webbing. It can be painful, it can be concerning, and it certainly can limit activity. So we go back again to that group of lymphedema physical therapists, and we get them to do massage and stretching and range of motion techniques so that can be resolved as well. So the axilla is a tricky area. It's a necessary part of our surgery. The appropriateness of the surgical technique can help reduce some of those issues. But similar breast surgery teams should be equipped with ways of managing those complications as well.
It's sometimes confusing to learn that DCIS is considered a stage 0 or a precancer, but the current standard is to have surgery, maybe with radiation, maybe a mastectomy, sometimes endocrine therapy. What can you tell patients about DCIS to help them understand these recommended treatment pathways?
Yes, so DCIS is our pre-invasive breast cancer, and the two sides of that double-edged sword are that while it's pre-invasive, it's a stage 0 breast cancer, has very little effect on your overall outcome. The way it grows is it can't grow like it's blowing up a balloon. It grows up and down the ducts. And so it can become very widespread. So oftentimes we have to perform a mastectomy more often for women who have DCIS than women who have invasive cancer. But when they're working through their decisions, it's very similar to a woman with invasive cancer. How big is this extent? Can I get around it with a lumpectomy and still have a good cosmetic outcome? Do I have a genetic mutation that's going to increase my risk for a second cancer where I should consider something like a bilateral mastectomy? What's the size of my breast? Do I have a very small breast that's not going to accommodate much of a lumpectomy at all? Those are some of the things that they want to think about. But it really has to do with what can you do and what do you want to do? Because when you have options, it's really up to you to figure out what makes you feel most comfortable. You have to think about radiation. Do I want to do radiation? Do I want to do endocrine therapy? Lots of different pieces.
Thank you for watching today. You can view the rest of the Breast Health series by scanning the QR code or clicking the button on your screen. Take a look at the options for sharing the webinar series with a friend, and don't forget to check out the downloadable resource section. On behalf of Mammatome, we thank you for joining us as we navigated the breast health continuum from screening mammograms to diagnostic imaging and through biopsies and surgery. Take care.